Dr. Boback Ziaeian. Dr. Boback Ziaeian is an assistant professor of medicine at the David Geffen School of Medicine at UCLA in the Division of Cardiology. He graduated from the University of California, Irvine. He then completed his internal medicine training at Yale. He completed his UCLA Star Fellowship in Cardiovascular Diseases and doctorate degree in Health Policy and Management at UCLA's Fielding School of Public Health in 2016. His research focuses on disparities and high utilization of hospital services for heart failure patients. Dr. Ziaeian is the recipient of the American College of Cardiology Presidential Career Development Award for 2017, as well as a 3-year American Heart Association Scientist Development Grant. He is an early career investigator for the NIH-funded UC Disparities Center. He is the chair-elect of the 2024 ACA-AHA Committee for Performance Measurement. His primary research interests are in cardiovascular outcomes, disparities in cardiovascular care, cost effectiveness, and the quality of heart failure management.
All right, well, thank you for the kind introduction and inviting me to give grand rounds this week. So my talk is going to be about some concepts in implementation science and health services research, and that you kind of hear buzzwords over and over. But what does it mean, and what in theory should the future of healthcare look like for cardiovascular population health management? So my title is Improving Cardiovascular Care Management Within a Learning Health System. These are my disclosures. I don't have any. So just overview of what I plan on talking about. So what is a learning health system in theory? Do we currently see elements of that in how we practice medicine today? Spending some time talking about issues with data quality and how that interferes with both quality improvement and research. The next portion is going to be about how do we measure care quality and its limitations? And then what is really the future of developing these learning health systems? So this is not a new idea. In 2006, the Institute of Medicine put together a report and workshops to discuss this concept. So the IOM definition is for a learning health system is one in which science, informatics, incentives, and culture are aligned for continuous improvement, innovation, and equity, with best practices and discovery seamlessly embedded in the delivery process, individuals and families as active participants in all elements, and new knowledge generated as an integral byproduct of the delivery experience. So they wrote this 18 years ago. And so looking at how healthcare is currently delivered as we experience it as clinicians, as patients, I would think we haven't really achieved some of these lofty ideas. But the idea behind the learning health system is that we have a cycle of continuous improvement. So there's research that might improve the science of what we know works and doesn't work. That feeds into the evidence. That evidence then gets fed into practice. And then while practicing this evidence-based medicine, we're gathering data. And can we then use that data to see if it informs evidence? And you kind of get cyclical continuous improvement by learning by what you're doing. So you're systematically gathering and creating evidence, and you're applying the most promising evidence to improve care. I can't say I currently get any type of feedback on my clinical care in a systematic fashion. I don't think many of us in cardiology, we have the, at UCLA now, you have a tiered incentive for the faculty about their guideline-directed medical therapy, and there's certain performance measures. So sometimes you get sort of indirect measures on your performance, but within the VA, I don't remember as a fellow getting, other than evaluations, getting this type of continuous feedback about my practice with medicine. The AHA has a scientific statement on learning health systems for cardiovascular disease. Same type of models where you're getting practice, you're getting information about people's practice. This is leading to collecting metrics. You then analyze that data, interpret it, and try to implement strategies. And it's a cyclical, continuous improvement, as if we're some sort of factory line trying to minimize all the errors in our production while we're doing this. But it's hard to look for how we've currently implemented this and whether we're achieving a learning health care system. So when we do talk about performance measures, we know that there's considerable gaps in cardiovascular care. Hypertension has been a long known risk factor, yet we can't get people optimally managed for their blood pressure. Large portions of the population don't even get primary or secondary statin indications. Use of anticoagulation for stroke prevention. Many people with even known AFib are undertreated. Heart failure, there's big gaps in using guideline-directed medical therapy and not understood why there's so much variation in practice. Even things like recommending cardiac rehab for heart failure patients or for surgical patients, there's gaps there. So basically, wherever you look for some sort of class 1 indicated therapy, there's going to be gaps. So going to the hypertension example, this is from the Million Hearts, using our NHANES data, which is the best way to sample whether what the prevalence of hypertension is and whether people have it adequately managed. So in the US, using data from 2015 to 2018, 47.3% of adults had hypertension. That's 116 million people. Of those, the recommendations, only 21% would be maybe recommended for lifestyle-only modifications. The other 79% would be recommended for medical therapy in addition to lifestyle. When we look at who's controlled of those who should have a medication on board, only a quarter of those have their blood pressure controlled, and most of the country, 74%, have uncontrolled hypertension. And then there's a huge portion of the population, even though they know they have hypertension, that are untreated. So they're not getting adequate treatment. And this is using not even the current guidelines for higher risk populations to have a systolic less than 130. This is using the general population cutoffs of greater than 140/90. So currently doing a very poor job on just basic hypertension control. Looking at some studies from CHAMP Heart Failure Registry from Dr. Fonro, showing the same type of thing when you look at whether people are getting ACE, ARB, ARNI, beta blockers. The percentage who are actually treated with the agent tend to be not optimal. And then when you look at it, whether it's related to vital signs, like is it the patients who have lower blood pressures that are maybe more likely to not get it? That's not explaining the difference. Vital signs don't explain the gaps. There's some other factors that are contributing to these gaps. So this is my basic framework for how I think you would hope for things to happen. You get RCT evidence. That's the best type of evidence we have for the efficacy of an intervention. Those RCTs and practices get synthesized in a clinical guideline statement. We then take those guideline statements in our professional society, and I think AHA, ACC have sort of set the bar for how we go about synthesizing the evidence, and then translate those into performance measures, try to create guidance for health systems, insurers, whoever, of how you would go about measuring these class 1 recommended therapies and to monitor performance. And then after you sort of have measures to monitor, the goal is to implement them, to close those gaps in cares, to get everyone up to speed and ideally getting optimal care. Which leads me to what is implementation science? So it's a field of study that's focused on how do you maximize the uptake of evidence-based practices and close these observed gaps in care. So within health services implementation science world, there's often different types of research design that inform questions around implementation. The research designs can be sort of quasi-experimental, but there's also randomization and traditional health services designs that are similar to what a clinical trial would do. So one of the first challenges may be to understand the context of the gaps. So that's where you see a lot of implementation scientists have backgrounds in qualitative research. I collaborate with Allison Hamilton. She's at the VA in our health services group, and she's an anthropologist by training, but she understands how to explore what are sort of underlying reasons for a system not functioning properly, how to synthesize common experiences that patients or clinicians might have, and how you go about eliciting that type of information. And then there's a whole way of systematically analyzing these themes to sort of try to figure out what are the issues that are contributing to, perhaps if the focus is on a gap of care, what are those issues? As part of implementation, a big part is stakeholders. So, traditionally research has been very siloed. You have a principal investigator working on their project in their lab or group. But with implementation science, because you're trying to get health systems to change or identify these problems, you kind of need to get buy-in from patients, leadership in the operational aspects of healthcare, so administrators, insurers even, how are you going to go about selling people on an idea to show them that the way things are currently working, they might be losing money, they might be causing harm, it might be hurting their measures. So that stakeholder engagement is a big part of implementation science. And then as part of implementation science and health services research, you want to have really robust evidence. So sometimes that's obviously hard. Randomization is always ideal, but if you're trying to implement something in a clinic, you're often not randomizing at the patient level or the provider level. It might be something that's like cluster randomized, or it might be something where it's planned that you're going to do something and you want to study the effects of how you went about implementing it. And so a common thing you might see in the literature is something called a step wedge design. And that's where you have sort of a timetable for implementing changes, and then your selection of how you're doing those clusters as you step through them. As you do the implementation change, you can then study that step wedge in sort of a pseudo randomization process. And then even after maybe you have findings from whatever work you're doing within implementation science, there's a big aspect of dissemination. Is how are you going to disseminate the knowledge? How are you going to publish it? Get your stakeholders aware of it and spread that in the community so that other people can learn lessons from the implementation work you're doing. So from my perspective, and the reason I'm interested in this field and have made a career trying to answer these questions is I think the greatest burden for cardiovascular disease is related not to the need for new therapies, but not optimizing our current evidence-based care. So, the bulk of cardiovascular diseases, if we could achieve greater than 90% or near 100% performance on our class 1 therapies, I think that would help drive down the burden of cardiovascular disease. So from a population standpoint, so improving hypertension management, improving basic things like statin therapy, helping reduce smoking and drug use rates, and then even for chronic conditions like heart failure, where optimizing guideline therapy is going to be far more beneficial than, say, a new therapy added on to what we're currently able to do. So yeah, how do we generate evidence for this? In industry and tech, the big thing is they're constantly doing A/B testing. So, tech companies like Amazon and Facebook, randomization is part of their culture. They all have internal platforms for how they go about marketing their products and their advertising to folks to make sure that there's maximum engagement with the platform, maximum reach of and clicks. And so they can quickly randomize people to different formats of messaging or ad display or whatever to maximize people's addiction to using social media. So A/B testing is foundational to a lot of Silicon Valley companies, and they have internal platforms that are statistically rigorous and large sample sizes to be able to get some certainty of how tweaks in their system improve an outcome, which is something I think we don't routinely do in medicine, obviously, from a health services standpoint. But one of my mentors in residency, who's now the director of population health at NYU, she did a number of great papers during COVID where they could use sort of the same platform that they'd established within the healthcare system at NYU. But in 2019, she did this New England Journal paper where they basically tried to apply these ideas of A/B testing, doing low cost, but within a year, doing 8 different randomized studies. So a lot of these are EHR based. So like questioning what is a current practice that the health system is doing, and does it actually make a difference in any patient-related outcome or expenditure for health services that could be made more efficient. So like the first one example she did was increasing influenza vaccination rates, and they just changed the alerts and randomized patients on their platform that interfaced with basically Epic. And they found no difference really in this best practice that was provided to nurses. They randomized at the nursing level. So they tried to look at different practice alerts for increasing smoking cessation, and that would help with their performance measures for reimbursement from insurance. So there was an incentive financially to improve the receipt of smoking cessation recommendations. And so they sort of did a cost analysis there. And then looking at reducing preventative care gaps, they looked at the difference between mailed reminders versus no reminders. And they found that mailed reminders did not help with reducing preventative care receipt. And so by not mailing, they could save the health system like $25,000. Looking at how to increase wellness visits. So they did different telephone scripts, randomized people again to that. So they were all very simple interventions, but they created this platform to be able to A/B test a lot of different interventions that were low risk, which is an important aspect of this type of study, because they didn't have to go around and consent every patient, have them sign all these forms. These were all randomization type procedures to optimize care gaps or that didn't require consent. So they were very pragmatic in design. So I found this figure from a JAMA paper that kind of discusses this, although there was a big emphasis on precision medicine in this editorial. But just to reemphasize that these concepts are sort of separate but relational, that the learning health system idea is something where we're continuously improving the care we're delivering and monitoring a lot of different outcome data to change our practice. And then implementation science is almost a niche research area, but when the VA has an emphasis now is really tying implementation science to operational work. So really partnering with some of the people who have to manage the budgets and make decisions, that they should be more informed and more evidence-based. So doing more partnered operational and implementation science work. And then there's a whole separate concept of like precision medicine, of how to deliver the right care to the right person. There's been a big emphasis of genetics. I tend to find that generally genomics in most clinical situations may not explain much of the variation, but it's sort of a different concept I won't go into too much depth into. But before I get to that, is almost all limitations with research and inference and quality improvement is data quality. So unfortunately, if you have poor quality data, there aren't statistical methods that help you overcome that. If you've coded garbage into a database, you're not going to be able to make it any better. And so when people decide to run, big different models on poor quality data, you're getting garbage in, garbage out. So often you have things like machine learning and AI. Those methods still depend on high quality data. If things are missing, miscoded, or not classified appropriately, that's going to reflect poorly on your inference. So what happens with bad data quality? Well, first thing, you lose statistical power. So if things are sort of randomly miscategorized, if you're looking for a signal on some causal pathway, you're going to lose power in your sample, and it may bias it towards the null, but it may bias it in other directions as well. You could get spurious relationships between things that don't matter. And then you can have systematic biases introduced with bad data quality. So you can propagate, even worsen race ethnic discrimination just based on perhaps where people get their care and how they're coded. That doesn't really reflect on any type of biologic difference. People can be misdiagnosed if you have bad quality data in your models. You can also overstate or understate risk if your model if you have poor event capture or things like that. And then the biggest thing is always unmeasured confounding. There might be really critical variables that inform some causal pathway, but if they're not available and there's nothing correlates with them in your data, that's going to create problems in the relationships you're looking for, no matter the statistical or fancy modern method you're using. So this was recently in the news, and I thought it was relevant to the data quality issue. So there's a paper, I think it was in Nature, that questioned this concern that there's been an accelerating maternal mortality rate in the US. And it's very hard to compare things like maternal mortality trends even, or between countries, because different countries use different methods of how they classify things. So even for death certification, there's always concern about how accurate death certificates are. There isn't, like formal training that everyone has to go through. There isn't auditing of correction of even death certificates. They're basically just signed off by physicians in the hospital setting, and then very rarely do people get actual autopsies from pathologists that would be well informed about death certification. But in 2018, these researchers had appreciated that the death certificates had changed, and they added a unique box on the death certificate. So if you filled out a death certificate, sometimes there's a box that says like, was smoking related to this condition? With COVID, they added a special COVID field to keep track of perhaps mortality that was related to a novel virus. But in 2018, they added a box for pregnancy to see if there was a recent pregnancy that might relate to the death. And since then, they found that there's been overclassification of the pregnancy box. And so they did this not by reviewing all the deaths that are coded necessarily, but they looked at, well, was the primary cause of death, is that even possible to be related to pregnancy? So like one example that they give is that cancer, if someone died of cancer, that should not be something that you would want to click the box for pregnancy for, because pregnancy doesn't contribute to the cancer diagnosis. And so calling that a pregnancy-related death would be inappropriate. So when they adjusted the mortality rates, rather than the CDC, 32.9 women per 100,000 dying related to pregnancy, it was only about 10.4, which is pretty stable and flat and not necessarily accelerating. And they noted something like, when the 2018 box was added, that there was a 46-fold increase in the number of deaths related to pregnancy and cancer. So it went from 0.03 to 1.42. So this was just a change in a definition in a form, and it led to sort of misreading the trends from that. Similar things have happened, like when I use hospitalization data, it's always mindful to know how ICD coding has changed. So like in 2011, I think, around there, they introduced a new set of CKD codes. It used to only be like one generic code for CKD, and no one really coded it much. But there was a financial incentive to actually code whether someone had CKD stage 4 or 5, and it would change reimbursement. And so there was a sudden spike. If you look at older ICD-10 versus newer ICD-10, a simple update like that to coding will create new trends, and new rates of disease that we hadn't appreciated. So you want to go about creating a performance and quality measure, but you have to always be mindful of what is the source of your data and how reliably can it be measured. So performance and quality measures are important. They inform research, they inform policy. If we're moving towards a learning health system, you want to have reliable measures to look at. We use them for quality improvement. We want to give people feedback, clinicians, clinics, hospitals. There are quality improvement models for implementation, things like Plan, Do, Study, Act, Six Sigma. They're all sort of similar to that learning health system idea. You want to do something, you want to plan on how you're doing it, you want to look at what the outcomes are and respond to it. And then sort of implementation science, I already talked about this, how to close these gaps in a more efficient way. So you want to create a performance measure. So yeah, the way on the HACC guidelines, the way we think about this is we go through all the class 1 recommendations and think about what could be operationalized. We also look at the class 3 recommendations, so things that are harmful and maybe need to be monitored and not done, like medications that shouldn't be used in heart failure can be a performance measure. And then step 2, you want to look at the constructability. Is this something we can reasonably measure? Is this something that the EHR could help us measure? Does it require like continuous chart review and audit where it's not really practical? And then the next step is, how do you go about incentivizing that performance measure? This is a big challenge, and people try to figure out whether within their system or how insurers think about this, how Medicare thinks about whether to incentivize something. ACCHA's goal is always to pass on our performance measures to Medicare to see if they'll consider them for their payment incentive plans. And then the next step with the performance measure is, once you sort of have a reliable measure, you want to incentivize it. You want to start thinking about, well, is this contributing to any sort of health equity or disparities issues? And once that measure is in place and it's being used, I think it's also important to then think about, are there unintended consequences to these performance measures? So I like this, Goodhart's law is that any observed statistical regularity will tend to collapse once pressure is placed upon it for control purposes. So it's a big problem when you create a metric. I think the example Goodhart kind of uses is like in Russia during the communist era, when they wanted to, companies would be rewarded for how many bolts they could make. And so some companies, when you put an incentive out to make more bolts, they decided rather than use up more steel, they would make the bolts smaller. And so people have these and they didn't anticipate that. They just wanted to improve production, but then people start making smaller bolts or something in response to it. So e-measurement is trying to sort of automate this within the EHR. That's sort of the IOM goal, is, advent of computers and everything. We were expected to have computers that made care delivery easier, but almost always it just increases work. You make it easier for patients to message clinicians, then you get burnout and inboxes overloaded and unpaid work for constant communication with patients. So it's very hard to think about how you're going to go about implementing these things. But yeah, you get measurement error with e-measures. You can have false attribution. So, perhaps you have the measure shows a failure for your panel, even though they got the treatment they should have, it just wasn't coded properly. Example could be ejection fractions. Patients may be labeled as heart failure and they no longer have it, and they're counting against you. This is a big challenge in the VA, where every VA kind of uses a different imaging system, different reporting system. And so the Utah informatics group has sort of been leading the way on how to use natural language processing to improve that, but they continuously sort of try to improve upon their algorithms to just get a simple measure like LVEF standardized from the EHR. You can have under ascertainment, so you can have lack of coding. You're just not seeing people with the same condition. It's not being captured. You can have variables omitted. Things like maybe a patient doesn't want to take a medication. There's no routine way that people reflect that there was a patient preference that they didn't take a medication. It was offered. And then you can have these perverse incentives, financial or pay related to these measures. So I would say that since the IOM has written their guidance on learning health systems, as clinicians in our routine practice, we don't really think about how to improve the delivery of care as, the front line. A lot of this is happening on the back end. So I think of it as we have more of a learning billing system. Almost all performance measures that are operationalized are tied to payment. And so some examples of that are Medicare is the leading, funder of healthcare in the country. They take care of everyone who's old, who has medical problems, people who are disabled through the Medicaid program. And they've created various quality improvement programs that depend upon performance measurement. These performance measures really they don't change that often, but once they're implemented, they try to make adjustments in them. So the hospital readmission program, something Dr. Fonro has written extensively about, and I have as well, is looking at how often do people get readmitted after they have a heart attack, COPD, heart failure, pneumonia, CABG, hip replacement, or knee replacement. And you get penalized in your payments if in your risk-adjusted readmission rate is higher than it should be for your hospital's predicted readmission rate. There's also the quality payment program within CMS. So there's MIPS, which is a merit-based incentive payment, and they have a bunch of MIPS measures. And then there's a different alternative model sort of for smaller practices called the Advanced Alternative Payment Model. And then Medicare Advantage, Medicare Advantage is where, as a growing portion of the Medicare budget, it's being outsourced to insurance companies to manage the risk for a panel of Medicare patients. They also have required measures in their program, and that's how they sort of get their star ratings from CMS that might incentivize patients when patients are trying to decide which plan to pick. But it's basically a 5-star rating. But the measures that they use are Part C and D performance quality measures. HEDIS is a very standardized set of outpatient measures. The VA uses this too, and it's usually a random sample. So there's companies that'll sort of go through charts and code the HEDIS measures. Health and outcomes survey is a different measure, and then there's the CAPS measures. So example of some of these that are cardiovascular related, there's 38 measures for the CMS star rating. Statin therapy for people with cardiovascular disease is one. So the more people who have a coded history of cardiovascular disease who are on a statin, the higher you are on that, it'll influence your payment. And then diabetes kidney care monitoring. So there's always been an emphasis on diabetes care. So checking A1Cs regularly, and then even monitoring kidney function for people who have CKD gets rated on how often people are getting tested. So what happens though is when a hospital or say a Medicare Advantage program wants to improve their payment, is they, rather than actually pay for on the ground improvements often, it's much easier to improve your profits or your revenue by having better coding. So we tend to have basically dedicated folks who are coders to help capture these performance measures, increase the complexity of care, and all those things, but it never really touches the front line of medicine. So that's why I think we have more of a learning billing system. We're responding to these measures mostly to maximize payment, and it's often very hard to see like the clinical experience of how it's improving care. So unintended consequences. So getting back to one of the main targets that has been written about is the hospital reduction program, readmission program. So they withheld 3% of all Medicare payments for risk-adjusted heart failure hospitalizations. Since implementation of the program, people saw that heart failure mortality actually increased. Most of the changes and improvements in readmission rates had to do with gaming coding. It's much easier to just increase the severity of the patients you're managing to change your risk-adjusted predicted formula. It's also better to maybe do more ED obs and not admit, so that you're not taking patients who might actually need hospital care in. And so there might be all these perverse incentives to try to reduce this number that is tied to reimbursement. But the systematic bias of HRRP that's been shown is that it continued to penalize low-income hospitals for incomplete risk adjustment. So they didn't have the resources to have the coders. So if you're in a poor neighborhood, county hospital, whatever, not only were your patients probably higher risk, but because you didn't upcode like everyone else could, you got even worse disparities because your budget was slashed in response to it. So there's debates about how harmful this might have been by creating a performance measure tied to payment without thinking about how it could be gamed or worsen care. So, all right, I'll try to transition to some of my own work in understanding population health and trying to, use some of the informatics tools to improve, especially outpatient care. So VA has a special office called Academic Detailing. It's a group of pharmacists and informaticists. Often there have been clinical pharmacists who did informatics training, and they create these dashboards that are meant to align with evidence-based care for various conditions. So the VA is the largest integrated healthcare system in the world. They still promote that idea. There's 9 million veterans in the system. And it's integrated because we include outpatient, inpatient care. There's, even housing now as part of our mission for the homeless veterans, short-term, long-term care, and pharmacy services. 1,300 healthcare facilities and 172 medical centers. And I think academic detailing is an actual good example of what's possible with a learning healthcare system. So Nick Braunwald, our wonderful star fellow finishing up this year, led this paper where we went through the first iteration of the academic detailing heart failure dashboard. So every VA, any clinician within the VA can go pull up their VA's healthcare system performance on heart failure measures. And you can go down to your own panel. If you have patients assigned to you as a primary cardiologist, you can look at your own performance, and then you can compare that to the national average or whatever. But in the second iteration, we went through and tried to make sure they aligned with the current clinical guidelines for heart failure care, and also try to anticipate what might be new additions that were coming down the pipeline. We color coded them for green measures would be class 1, yellow measures or orange measures were 2A, and then yellow sort of 2B, or orange 2B and yellow 2A. And so some of them they're grouped by HFrEF. So you have guideline directed medical therapy for HFrEF. You have your RAS inhibitors, ARNI, beta blocker, SGLT2s. And then usually there's a percentage here that shows you the score of your facility and then the national average. And then it gives you in blue, when you click on these links, it takes you to the patients who have the gaps in care. So you can actually go through and respond to them. But when the dashboard was first released, I wasn't involved with that development, but they had some rules and definitions that led to people feeling like they would try to go in and see why they weren't getting good scores on their heart failure management. And when chart reviewing, they felt like the patients didn't actually have heart failure, and it was being the denominators were way off. And so we did a chart review to check on how well was the dashboard performing. And so the sensitivity was high for HFrEF, 98%, but the specificity was not very good. It was 35%. And so, yeah, there was a lot of overdiagnosis and misclassification. And then it was around the time that they came out with, heart failure recovered should be a group that we consider, and how to think about performance measures for them. And then they also did very poorly with just identifying like HFpEF, which would be important if you're starting to look at measures like for SGLT2. So in the second iteration, we came up with more of a hierarchical way of considering where the ejection fraction data was coming from. So one problem with natural language processing we realized is it was pulling EFs from nuclear studies of gallbladders. And so, you want to exclude perhaps the EFs coming from nuclear studies if there's another better source that you can use. And so we came up with a hierarchy where, if it was an echo, a cardiac MRI, those were sort of high quality studies, especially if the numbers reported were consistent with what you would see in an echo report. And while we improve the positive predictive, negative predictive value of just classifying different heart failure types, we did lose some sensitivity, but it was hard to figure out what rules could help us capture more patients. But the dashboard basically requires that as an outpatient, or whether inpatient or outpatient, someone has coded a diagnosis for heart failure using ICD codes. And there is no ICD code still yet for HFrEF, HFmrEF, or HFpEF. You can try to sort of use the diastolic, systolic codes, and there's no code for like recovered EF either. So you have to have a code for heart failure, any type, and then you have to have the natural language processing most recent variable for, or some source for ejection fraction to help classify. So we wrote a paper about how we can improve the classification and how that helps improve the reliability of our performance measures to make the ability to measure variations in care and also act on them more reliable. I sort of did the same study where I was interested in seeing how much regional differences there were in heart failure care. So this is just distribution of total veterans with heart failure by county. Darker blue means there's more heart failure patients there. So we actually have per population lower rates in California. Looking at different VA medical centers, the distribution of GDMT, there's wide variation. Some places have RAS inhibition up to near 90%, while other ones are below 60%. And so whenever you look for how well are people doing on a standardized measure, there's always variability, and it's not understood really why. But we went ahead and we tried to look at standardized ways of visualizing variations in GDMT. Sort of this slide's sort of busy, but in A, we're looking at the absolute rates by geography of who's receiving a RAS inhibitor. And so those rates tend to be high. At the time of our study, ARNI rates were still kind of low, so just in like the 10 to 20% range. And then we have beta blockers were pretty high, so closer to 80, 90%, higher than RAS. And then SGLT2s were fairly new, but still very low uptake. And then we created Z-scores to show variation. So we standardized the measures. And then if you were an outlier in performance, you were more towards the orange scale. If you were a high performer on the scale, you were in the blue. And so this map here is combined for all guideline therapy where were the highest rates. And so this area of Texas seemed to consistently score higher for GDMT for their HFrEF patients. And so we gave some examples of how much the interquartile ranges varied by VA healthcare centers, who was considered like a high performer versus the low performing regions. And then trying to figure out how we could target ways of improving care in these regions that are either high or low or low performers. So what do we know that does work for improving cardiovascular care? So reducing barriers, so improving access to outpatient care, especially specialty care. Often it's tied to out-of-pocket expenses, insurance coverage, financial barriers to just getting indicated therapies. There's team-based care approaches that are shown to work. So when you include pharmacists and have a team-based approach, nurse practitioners or physician assistants, people who can just focus on a certain performance measure or evidence-based quality of care area, they tend to improve uptake of an evidence-based care. Let me go, I kind of already went through this. And I'll just go on to my dashboard study. Since I'm running a little bit out of time, I want to hear some comments and feedback. So do population dashboards work? So that was a question. We have this great VA dashboard. I did this study. It was led by, she was an intern when she started, when we went through the approvals process, and now Ardhana is a fellow at Stanford, but she helped me do a pragmatic RCT unfunded using the dashboard where we either randomize patients to usual care, so whatever their primary care and cardiology we're currently doing, versus getting a proactive population approach where a half day of clinic we envisioned would be someone sitting at this dashboard and going through the patients with the biggest gaps in care and trying to figure out why and trying to see if we could get medications back on. And so there was an attempt to do basically a chart audit of every of these, the 150 who got the intervention, if they had heart failure and whether they had a need for perhaps being reintegrated into care. And then during the same time, we would impromptu either call patients or try to get them to do a telemedicine visit impromptu. And then if we couldn't get a hold of them, we would leave a note for primary care and their cardiology provider. And then we would also try to mail them a letter to encourage them to contact the VA to be seen in our heart failure clinic if we felt like they had gaps in care. So this was our flow diagram for randomization. There was no consent required since it's not all the therapies are already approved for heart failure. We're just sort of randomizing people to a different way of delivering a health service, proactive versus usual care. Our outcome of interest was an optimization potential score. We thought of this in terms of, at the time, the current steps a person would have to go through to get on optimal medical therapy for HFrEF, and then giving points for each stage of that. And then these are some of the baseline characteristics of our GLA heart failure population and the medication rates we saw at baseline. So we took the patients with the lowest optimization scores. So 0 meant you were on no HFrEF therapies, despite the dashboard saying you had HFrEF. And then the points here you get for being on a low dose or on a target dose of any of the classes. This is the outcome of our study. So it was fun to get to do an RCT and come up with like, how am I going to statistically analyze this and how am I going to power it? But the composite measure we thought would be a good way of a single outcome that was sort of linear. And then we did baseline. We had a pre-planned baseline adjustment based on some patient characteristics we think would relate to the outcome of interest. So that helps improve your power, often not done in many RCTs. And then, unfortunately, we didn't meet our primary outcome, but, small study, everything trended in the right direction. And so we have some color coding of how that looked. This is at baseline, the rates, the optimization score for usual care at top and the intervention. And then you can see in the usual care at 6 months, there was slight improvement over time in general for both arms, but it looked like the intervention arm did a little bit better, a little bit faster in terms of optimizing. But the big thing we found is that, and this probably makes sense up front, but it was important for us to figure out why are the patients who are not optimized, the least optimized patients, why is that? And we found in our population that 41% had either been homeless, actively using substances, or severely psychiatrically ill. And so that ends up underpowering our intervention, because our whole point was just to do a single sort of reach out to the patient, see how you're doing. But if you're currently homeless or abusing substances, a phone call isn't going to really change that. So this has been seen in some other heart failure studies where if patients were depressed, they were less likely to, say, engage in telehealth. And so I think if you're going to do a very low resource intervention, you need to target patients that are going to respond to that. So for next time, if I do this again, I'm going to try to exclude these, because this population, although very important, requires a much intensive team, our homeless pact at the VA, and more resources to figure out, dealing with their social issues first before prioritizing, say, GDMT. I was going to talk about artificial intelligence a little bit as it relates to big data, but I don't think I have time to sort of get into it. But it's very hot right now, and a lot of people shift. Even the VA has started to emphasize, in addition to homelessness research and other health services work, they've mentioned AI as a priority to help offload things. But a big problem in sort of machine learning AI research is that people are not being systematic about how well the new model compares to what does it add in addition to just statistical methods we already have. And so often they're applied to very small samples, clinical data, and it's not really outperforming just our common statistical models that are informed by clinical knowledge and other things. But anyway, I'll skip over that. So in closing, so how do we go about building better health systems? So partnering clinicians, patients, what would make their care easier, lowering barriers. Sometimes it might be better clinical decision support, making things easier to order, reducing clicks, making things easier to get through, and trying to figure out what are sort of the patients doing in terms of their barriers to care. So in terms of the future of cardiovascular care improvement, how do we go about developing a platform to reliably measure care quality? My emphasis is in learning on how to develop and do sort of more pragmatic RCTs, doing more sort of A/B testing of interventions, and figuring out how to scale that to be low-cost studies and useful information that can change care and be related to how we implement changes in our healthcare system. So I'll go ahead and take some questions. Sorry for not leaving much time. But thanks for having me.
Hey, Boback, that was really nice. My question for you is, how much do you think physician level financial motivation can play, either in the form of penalties or financial rewards, as far as influencing quality?
Yeah, so there's kind of limited studies to my awareness. I'm sure you probably know the literature even better than me, but I think it's been looked at in, like, even in NHS populations. If you create a financial incentive, can you improve a metric? In general, I haven't seen, I think there's reviews saying that financial incentives haven't made that much of an impact on changing clinical care. But I think what happens though, if a certain measure becomes a financial measure or something that's rated, Yeah, I mean, you look at acute MI care and how quickly or how long it took, but eventually people getting above 90% on certain measures, like people getting aspirin, even door to balloon times. There's certain measures that get retired because of the attention that they receive. And the problem is there's so many different class 1 recommendations now is how do you go about doing that for everything. So I think things that are certainly high yield when they get this type of attention, and they're important and it's something they can modify, it does become a sort of a tool for dissemination. So I'm sure even though UCLA has gone to this for their faculty, is at least GDMT is being hammered repeatedly because you're being exposed to this idea that every time you see a patient, are you looking for these opportunities to maximize their current guideline therapy? But yeah, I don't think financial incentives directly have been shown to either be worth the investment or directly help speed up the process for doing that. But yeah, I'm sure other people have their ideas of or other examples that might have worked. Yeah, I get my frustration is I think most quality measures are now packaged into insurance payment through CMS, and even insurers have their own pay for performance programs. And often it's driven by coding emphasis rather than any type of effort to improve, implementation of the actual evidence-based therapy. All right, and anything else? All right, well, it's top of the hour, but feel free to reach out or let me know if you have any questions.